So I'm going to talk about the debate between one or two incisions for distal biceps tear. So initially, the attempts to repair this distal biceps tears were doing through an anterior approach, and interestingly, before the advent of anchors, this was done. The distal biceps was sutured onto the brachialis. But then, with the advent of suture anchors, this was done onto the radial tuberosity. And this was an extensive anterior approach. It was found that this extensive incision was associated with a high rate of radial nerve palsy, and on top of that, the anatomical footprint was not restored because, as we're talking, you cannot go all the way back and to the ulnar side of the radial tuberosity through one anterior incision. So then Boyd, in 1961, he described the two-incision approach where there was like one smaller anterior incision and one large posterior incision. And the initial technique was done through an extensive posterior approach. You were detaching off all the anconees from the ulna. You were exposing the periosteum of the ulnar. And this exposure of the periosteum of the ulnar was associated with a high rate of HO and synostosis. So then the group from Mayo in 2000, they modified this technique. So as you can see, there was done through a smaller incision. You can see with the white arrows the initial technique, and with the black arrows the modification. So the Mayo group modified that, and you were going with a Cayley between the ECU and the EDC. You were not detaching the anconees. You were not exposing the ulna, so you could go from the front to the back or from the back to the front and create the pathway for the tendon. So today we're here between one incision with anchors, battens, or biotenodesis screws, or with this modified, more limited posterior approach. So the three main questions is which one is safer in terms of nerve injuries, which one is associated with more HO, and if there are any difference in functional results. So when it comes to the PIN injury, it has been most likely the two mechanisms that they can result in PIN injury. If you put a Hohmann on the back and radial side of the radius, and I don't think that anyone is doing that, or if you do the transcortical drilling, especially if you're aiming, Dr. Papadopoulos said that, especially if you're aiming to distal. So I'm going to just present shortly some data from the literature regarding the PIN injury. There are three meta-analyses assessing that. The first one showed that the double incision is safer because double incision was associated with 0.2% of PIN injury versus 2.7%. But the two subsequent meta-analyses showed that there is no difference between the PIN injury. And I think that's the case. When it comes to HO, data from meta-analysis has been shown that HO is the rate of HO is higher in double incision. If that is clinically relevant or not, we don't know. And when it comes to functional outcomes, there was one meta-analysis in Bone and Joint Journal in 2020, and they found that the single incision results in greater elbow flexion pronation. And maybe that's associated with a lower rate of HO. But the differences in DAS score, there was no difference in DAS score between the two techniques. There's an interesting study from UPMC. Dr. Smith, they compared 15 patients with a double incision technique and 17 patients with a single incision technique. And they found that the anatomical footprint was restored in a higher rate in the double incision group. And the double incision group had significantly greater supination strength than the single incision group. And that's the opposite of what Dr. Padnis found. But the interesting part in this study is that the supination strength, initially when the patients were doing the supination strength test, was similar. But then after a while, the single incision technique, these patients were getting more tired. So the supination strength was going down after a while. So that's something that you have to keep in mind. Maybe the supination strength goes down after a while when the footprint is not anatomically restored. And if you think about it, that's why we do the surgery, right? Not for elbow strength, not for elbow flexion strength or anything else, just for supination strength. But at the same time, the double incision group had a significantly greater supinator fat content. As you can see, the MRI is here. In the middle picture, you can see that there's more fat in the supinator because this is the double incision group. You go through the supinator compared to the right picture where there's no fat in the supinator, the single incision group. So the authors concluded that the predictors of the restoration of supination strength is the anatomic reinsertion of the rupture tendon and limited supinator muscle fat content. So in order to stay safe with a PIN, you can do 1 or 2 incisions. You just have to follow the rules. I was kind of lucky because I was trained doing both techniques. If you do the double incision, you have to mark where the PIN sits, and that's usually between the 1/3 between the distance of the tip of the olecranon and the radial styloid. I'm always marking that point. Then I go 5 to 6 centimeters distal to the tip of the olecranon and 2 centimeters radial to that. That's going to be the midpoint of my incision. And I never go beyond the mark of the PIN, where the PIN sits. If you do the single incision, you should never put a Hohmann on the lateral and back side of the radius. And in my opinion, you have to avoid transcortical drilling. I think it's a bad technique to put a baton on the back of the radius, doing like a transcortical baton through an anterior approach. Unicortical batons work better. And in order to minimize HO, you have to, of course, avoid muscle damage and extensive use of bovi. You have to avoid excessive drilling. You should never expose the periosteum of the ulna. And if you can't, you have to cover the full bony bed of the prepared footprint with a tendon. Thank you.